Welcome to the Pediatric Shift Care Training presented by the Office of Medical Assistance Programs. This training was held live on September 14th, 2023. This training is presented by Sarah Weir and Laura Thur of the Clinical Quality Unit. Please note the following disclaimer. While these are current requirements and language regarding denials and shift care, the Health Choices Agreement is a constantly evolving document. The Health Choices Agreement is reviewed and released annually, with OPS memos and MA bulletins released as needed for clarification, changes, and expansions. Language and requirements are changed to best meet the evolving needs of the Medicaid population. The information in this presentation is current as of September 2023, but please ensure that you are utilizing the most current version of the Health Choices Agreement, OPS memos, MA bulletins, etc. when referencing this as a resource or as a training material.
Hello, everyone. Today, we're going to lay the groundwork for our presentation. These statistics show the impact that shift care has on the Medicaid pediatric population. This is not a small issue and must be looked at accordingly. Requests that are appropriately reviewed the first time will have a huge impact on the workload of both the MCO, the member, and the department. Throughout the presentation, I want you to keep this definition of medically necessary in your mind. All requests for services must be reviewed for medical necessity. I want to draw your attention to the last part of this definition. Will assist the member to achieve or maintain maximum functional capacity in performing daily activities. Just because there is no improvement does not mean that services are automatically no longer medically necessary. The emphasis here is on maintain functional capacity. We see this a lot in therapy cases and shift care cases where continued services are denied because of no improvement, but the member is at their full functional ability. In conjunction with ensuring decisions are based on medical necessity, Exhibit J of the Health Choices Agreement states that providers and MCOs must arrange for all medically necessary care. This is an integral part of the provider's continuing care responsibility after a screen or other health care contact. In cases involving a member under the age of 21 with complex medical needs or serious or multiple disabilities or illnesses, case management services must be offered. For the ongoing coordination of EPSDT services for members under the age of 21 identified with special needs, the MCO must appoint a representative who will ensure coordination with other health, education, and human services systems in the development of a comprehensive individual family services plan. All children with special needs should always have a set of eyes on them from the MCO. Needs change constantly, and the MCOs need to be continuously assessing the members' needs, especially for members identified with special needs. This coordination can ultimately lead to a less arduous process during authorizations for shift care. The definition of special needs is very broad and inclusive of a multitude of diagnoses, including physical, developmental, emotional, or behavioral conditions, and even life circumstances that cause a barrier to the member's access to care or services. The one special needs population that we are going to focus on today is the children with special health care needs, including those requiring skilled or unskilled home shift care. The Case Management Society of America releases care management standards every couple of years. These standards are what special needs staff are required to use to case manage members with special needs. Exhibit N and NN1 in the Health Choices Agreement are greatly based on these standards and are the basic requirement of the MCO's Special Needs Unit. I have provided some highlights of the standards. While all are very important, we are going to focus on the 5 principles highlighted in red. using a client-centric collaborative partnership approach that is responsive to the individual client's culture, preferences, needs, and values. Using a comprehensive, holistic, and compassionate approach to care delivery that integrates a client's medical, behavioral, social, psychological, functional, and other needs, promoting optimal client safety at the individual, organizational, and community levels, facilitating awareness of and connections with community supports and resources, and fostering safe and manageable navigation through the healthcare system to enhance the client's timely access to services and achieve desired outcomes. We have all seen a chart similar to this one. Person-centered care is when the member is at the center of everything, all interactions, care coordination, etc. Everything gets linked back to what is best for the member. What are their clinical needs? What medical diagnoses do they have? And what items at home do they need to take care of those medical needs? What do they need non-clinically? What services do they need to address social determinants of health? What community resources do they have, or what community resources do they need? Do they qualify for any other services? Personal. What is their support system? Do they go to school, and what are their needs there? What are their personal beliefs and goals which would affect their care? And familial. What is their home life like? What are the family dynamics? What does the family need? Remember, it all focuses back on the member. We are now going to move into a discussion on denials. Each MCO is required to have their own utilization management process for prior authorization. This process must be outlined and described in their prior authorization policy. If the MCO wants to require prior authorization of any service or item, they must establish and maintain a written policy and procedure for that service or item. Any prior authorization policy must adhere to the 8 regulations listed here. This policy must then be submitted via the PARP process for approval prior to implementation. More details are available in Exhibit H of the Health Choices Agreement. Denials are exactly what their name implies, the denial of a requested service or item. There are 3 types of denials: a complete denial of the service or item, a partial denial, or an approval of a different service or item. For each of these types of denials, there is a specific department-provided denial template. These templates must be followed in their entirety and used appropriately. For instance, you cannot use the complete denial template or the N1 and then use the notice to actually partially deny or approve a different service or item. You must use the appropriate template. These denials must also be member-specific and list the specific reasons for the denial. The Health Choices Agreement has several areas that cover the expectations and requirements for the denials process. In Section 5 of the Health Choices Agreement provides some basic requirements, including review timeframes and timeframes for sending the denial notices to the member and to providers. Exhibit H outlines the prior authorization requirements. Exhibit M1 outlines the utilization management requirements for the prior authorization policies and procedures. And Exhibit N outlines the required denial notice templates. For our particular area, we focus on denial templates 1, 2, 3, and 7. All denials must be based on medical necessity. There are 4 regulatory reasons based on medical necessity for denial. 1, the service or item is not medically necessary. This means that the information provided for review does not show that the criteria is met, showing that the service or item is medically necessary for the member. 2, The service or item is not covered under the Medicaid program. 3. The service or item is not covered under the member's benefit package. 4. The service or item is denied due to lack of information. Number 4 can only be used in certain instances. The additional information was requested using the N7 template. There was outreach to the provider, family, etc. to obtain any missing information. Anyone that can reasonably be able to get the information needed to complete or gather the information for the request is able to make this outreach. However, this is not the medical director's peer-to-peer that happens prior to denial. That must be completed by the denying medical director to the ordering physician. And 3, any additional information gathered could lead to an approval. Don't request information that is going to be extraneous. You only want to request information that is going to help determine medical necessity. These 4 regulatory reasons must be listed verbatim in the denial notice. There is no regulation that allows a denial to be issued for administrative reasons. For an example, a denial rationale in the notice cannot say, "This service is denied because it does not meet the administrative criteria." This is unacceptable and not based in medical necessity. The definition of medical necessity also cannot be used as a denial rationale. A denial notice reading, "This service is denied because it does not meet the definition of medical necessity," is unacceptable. Clinical staff have observed rationale stating that a service or item is denied because it does not meet Health Choice's definition of medical necessity without any further explanation. This is not an appropriate denial. Denials issued on the basis of medical necessity must state that the requested service or item is not medically necessary because, and then provide the member-specific reason for the denial. The Division for Quality and Special Needs Coordination monitors the number of denials monthly via the QM-UM7 denials log report. We monitor for trends, gaps, and large increases or decreases in the number of denials of a particular area, and any major changes overall. The Complaints, Grievances, and Appeals area monitors the grievances, external reviews, overturns, and the number of upheld. The ratio between these 2 sets of numbers is also monitored to observe and alert for services that could have possibly been denied inappropriately. Denials due to the lack of information must specify exactly what information needs to be submitted in order for medical necessity to be determined. However, this does not mean to list all requirements, just those specific to the member. For those under age 21, services and items cannot be denied without at least 3 attempts for a peer-to-peer between the denying medical director and the ordering provider prior to the denial. These outreaches must be documented in the case notes. Personal care services cannot be denied based on the member's diagnoses or because the need for assistance is the result of a cognitive impairment. Assistance may be in the form of hands-on assistance or actually performing a personal care task for the member, or queuing so that the member performs the task by his or herself. Criteria cannot be arbitrary or capricious. It must have a documented scientific basis, must be appropriate to the population it is being used for. The criteria must be interpreted for the member and the provider in the denial notice. This is one of the reasons for the 6th grade reading requirement. And MCOs cannot deny hours for specific times, for example, days, nights, school hours, etc., when the missing information does not pertain to the specific time period, should be handled as approved other than requested. We have provided an example here of an unacceptable denial language versus a good denial language. The unacceptable one has no basis on medical necessity, no actual reasons for the denial, and no specifics for the member. The acceptable example has the regulatory reason verbatim, the member-specific information, and member-specific reasoning for the denial. This graphic should look familiar, but there is a slight difference in that this shows the factors that affect medical necessity determinations in relation to shift care. This shows that it's not just a checklist of items to show medical necessity, but the entire person. What are their physical needs, their behavioral needs, and not just from a diagnosis, but their developmental needs as well? What are their support systems? What social determinants of health needs do they have? What are their stressors and supports? Is the person's mental health being taken into account? Again, not just because of a diagnosis, but because their mental well-being can lead to physical implications. And finally, what is their home life like? What are a parent's responsibilities? What about their job? Do they have their own physical or mental limitations? What about other household responsibilities, other siblings, etc.? So how do you determine how many hours are medically necessary? Think of it as a funnel of hours. You start with 24 hours in a day. Then what does the member need? This will be described in the letter of medical necessity, but it may be expanded upon by other resources. Skilled nursing is a little easier to figure out, but home health and the activities of daily living tasks can be more difficult to quantify. That's one of the reasons why the ordering provider and the medical director should have conversations. And the medical director should also outreach to the family and even the home health agency if available. This also includes needs for schools, social determinants of health, and needs of the entire family and the member. Then you funnel down to caregiver sleep schedule. It's a well-known fact that people need to have 8 hours of sleep for their health and mental well-being. However, this does not mean that sleep has to happen overnight. You must look at the caregiver's job and their hours worked, leading nicely into the work schedule, including commute time. Here we have what the department is calling the chicken and the egg scenario. We have seen a lot of instances where the MCOs are denying services because caretakers have lost their job in order to care for the member. And then the MCO assumes that they are able, available, and willing to care for the child, and therefore the hours are denied. If a caretaker is actively looking for employment, they are not automatically able, available, and willing. Part of the Medicaid program is to help members and/or their families become gainfully employed. The MCO should be approving hours in order to allow parents and caretakers to look for an employment or go back to school, etc. This includes job searching, on-the-job training, travel, etc. This again goes back to medical necessity. By the Medicaid definition, getting the member and their family to a certain level of health and then maintaining at that level is part of that definition and therefore justifies approval. Parents and caregivers have other responsibilities as well that also need to be taken into account. Siblings, including their activities and needs, their school, college, sporting events, etc. Major life events such as weddings and funerals, household duties, appointment schedules, religious services. This includes other needs such as family time that address the holistic needs of the member, not just medical need. It is important to recognize that not all member need centers around a member's particular diagnosis. Mental well-being is important, not just for the member, but also the family. There are examples in coding manuals that reference caregiver stress, one being acute stress reaction. Other stressful life events affecting family and household must be taken into account. The bottom of the funnel is the caregiver free hours. Once all previous aspects are taken into account, the remaining hours can be assessed for ability, availability, and willingness to care for the member. If the information is not clear in the request, the MCO must have a conversation with the family about whether they are able, available, and willing to be the member's caregiver, not just make an assumption that they are. All of this basically to say you need to get the full picture to determine hours. It is not a straightforward process, and every case is different. Each MCO is required to have a shift care policy per the Health Choices Agreement. We've mentioned a few of these requirements earlier, but to reiterate, Section 5 of the Health Choices Agreement states that if the MCO wishes to require prior authorization of any services, they must establish and maintain written policies and procedures, which must have advance written approval by the department. The criteria for shift care coverage is reviewed and approved prior to implementation. This is all completed via the PARP process. Exhibit N1 requires the MCOs to submit all utilization management policies to the department. This includes the policy for their shift care review. This is via the QM-UM3 report. And lastly, each MCO is required by the new ops memo to integrate the new regulations into their policies. These revised policies were then reviewed by the department and approved for use. Next, we are going to review the specific requirements of Ops Memo number 5-23-004. Some of these have been previously discussed, but we are going to repeat them because they are in the Ops Memo and are important to remember. Managed care organizations are required to provide coverage in the same amount, duration, and scope as fee-for-service. Embedded here and in the resources section at the end of the presentation, we have provided the quick tips from fee-for-service that outline these requirements. Private duty nursing, personal care, and home care aid services for members under 21 must have the following. The legally responsible relative, or LRR, must be hired by the home health agency. The personal care services are used to assist the member with personal care needs. Personal care services cannot be denied based on a member diagnosis or because the need for assistance is a result of a cognitive impairment. Assistance can be hands-on or it may be queuing. Private duty nursing or shift nursing is nursing services provided to those under age 21 who need more individual and continuous care. And this can be provided by an RN or an LPN employed by the home health agency. Both skilled and unskilled services can both be ordered at the same time. The member is not limited to one or the other. It is up to the home health agency to assign staff based on their scope of practice. Services must not be denied because there is a parent or caregiver present in the home unless the MCO determines and substantiates that the parent or caregiver is able, willing, and available to provide the level and extent of care that the member needs. Other responsibilities include, but are not limited to, household duties such as shopping, housekeeping, laundry, yard work, errands, and other medical appointments, coordination of healthcare and services for the member, religious services, and care of other children in the home, including their extracurricular activities. The MCO must outreach to the family, and the ordering provider if the needs and circumstances are not clear in the provided notes for the request. Services must not be denied because the MCO believes the service should be part of an IEP. Medical necessity is based on the individual member's medical necessity, not the combined medical necessity of a family unit or siblings. And denial notices must explain specific reasons for the denial. Per Exhibit J, the MCO is responsible to provide all medically necessary services. Each request must be reviewed for medical necessity. Services may be provided outside of the home. If services are medically necessary, where the child is does not make a difference. This includes camps, schools, etc. The MCOs cannot have a minimum number of hours required for approval. Each MCO must have a process in place to obtain information to determine medical necessity. The MCO must outreach to prescribing provider and the member using the N7 template. If there is not enough information about the member's family and circumstances, including potential home caregivers in the case file, the MCO must outreach to the child's family, requesting provider, home health agencies, etc., to request additional information such as work schedules and other responsibilities in the home. Just sending the N7 template is not adequate. Additional outreach must be performed in order to get the necessary information to determine medical necessity. The MCOs may not deny coverage or limit the number of authorized hours that may be provided by an individual, specific nurses, or home health aides, including legally responsible relatives. The home health agency is responsible for identifying qualified, physically capable, safe, acceptable, and trained staff to provide the services. Responsibility of the home health agency to provide adequate supervision of nurses, and the home health agency to assure services are in accordance with the authorization and the agency's policies. An MCO does not have a say in who may staff the case. A caregiver cannot be excluded simply because they are a legally responsible relative. Staffing is handled by the home health agency, who then bears the responsibility to ensure staff is appropriately trained and performing their duties. The agencies are then in turn regulated by the Pennsylvania Department of Health. If a legally responsible adult is training to become a caregiver through the home health agency, the MCO may not deny the hours because the legally responsible relative is able and available. The parent or LRR will use the approved hours to complete their on-the-job training and certifications. The hours approved can then be staffed by another caregiver at the agency. This should not differ from the MCO's usual payment model. DHS does not involve themselves in how the MCOs pay the agencies. The agency cannot legally begin to pay the LRR until training is complete, but this should not and must not stop the hours from being approved if medically necessary. Now that we have laid the groundwork and provided the necessary background information, I'm going to hand it over to discuss and explain how the clinical unit looks at shift care services.
Now that we have covered the background information regarding prior authorization and denial of services, I will take a few minutes to explain the case review process. We will run through 7 cases and discuss the following. What does the clinical unit look to answer during the review process? What was done well and what would have been the source of issues or clinical concerns? What's missing from the cases? And what could the MCO have done differently to more closely align with DHS expectations regarding the process? The following 3 slides include a template outline of the information as well as some of the many questions asked during the review. Cases and discussions for today are in a more summarized form. Prior authorization case reviews typically involve the reading and review of hundreds of pages of documents. The clinical unit's full review also looks at the denial notice in depth and compares them to an internally developed audit template. The results of this comparison are what you see when your clinical monitor sends over the denial improvement audit results. Denial notice criteria reviewed includes use of correct denial template, adherence to template information and layout, presence of medical terminology or abbreviations, language level, readability of denial rationale. Readability includes, does the denial notice provide adequate information to fully explain the denial? Does it provide enough information to appeal the denial if the member desires? It's also important to note that everyone must speak the same language. Everyone includes the MCOs, providers, and members or families. These explanations should be meaningful and provide the information needed to resubmit the necessary information or move forward with a complaint or grievance. The clinical case review template includes the age of the member, the request received, the history that's pertinent to the member, the services requested, the hours requested, case notes, as well as any necessary information that is specific to the case. It's important to point out that establishing medical necessity is only the first step in the prior authorization process. This process is driven by the prescribing provider, and it is up to this provider to assess the member and their needs and to determine the hours necessary to meet those needs. This must all be described in the letter of medical necessity. If the MCO medical director feels the requested number of hours are inappropriate, this is a conversation that should occur between two medical professionals, and it should occur before the peer-to-peer outreach, since this is the final step in the determination process. This proactive communication will make the process smoother and more efficient in the long term for all parties, since hours and days will not be spent waiting for the prescribing provider to send information that may not exist to support what could be an inappropriate request. If medical necessity is not met, this is only the beginning of the review process. It is part of the MCO's duties to case manage these special needs members. If medical necessity criteria is not met, the MCO must determine what may be needed to establish and to request that information. The goal is to meet member need, not to deny necessary services as outlined in Exhibit J. When information is determined to be missing, you begin with a review of the internally available information that may have not been included in the prior authorization request. The MCO should then begin the process of outreach for what is still missing. It's important to note that the process is not linear and may require several instances of back and forth to obtain all necessary and pertinent data. We would also like to point out that there are some things, such as the need for sleep, that do not require documentation. It is generally accepted that a human being requires 8 hours of sleep. Hours that are included in an IEP do not need to be denied by the MCO. These hours can be authorized with the hours provided by either the school or the agency. The agency will be responsible for ensuring that the hours are not duplicated. This slide outlines the differences between MCO and home health agency responsibilities. The MCO is responsible to receive a request, review a request for services, determine if the request meets the medical necessity definition, to authorize the coverage for the services, and to partner with agencies per Health Choices Agreement standards. The home health agency is responsible to receive case referrals and authorizations, to find and procure appropriate and safe staffing, to train staff and maintain proper trainings and certifications, to monitor staff for safe practice standards, and to be aware of and adhere to DOH guidance regarding ratios and staffing hours. Sample case 1 involves a 5-year-old child. The date request received was 12/12 of 2022. The history of the member includes autism spectrum disorder. The services requested are to monitor for safety, meal preparation, bathing, incontinence care, and assistance with ADLs. The hours requested were for 40 hours of flex per week, with no specification for skilled nursing versus home health aid. The case notes indicate that a letter of medical necessity was received, and it was written within 6 months, dated 11/4 of 2022. However, it was noted at that time that it was not signed by the provider. The member's mother recently willingly gave up custody to the grandparents. The grandmother had to quit her job due to having to care for the member's needs and was unable to work while accommodating for those needs. The grandfather also works outside of the home 40+ hours per week. An N7 was sent on 12/12 that requested the following: caregiver work schedule, services requested. What were they for? Work, sleep, school. Was there anyone else in the home with special care needs? What other responsibilities did the caregivers have? How were the needs currently being met? Who lives in the home? Who is trained to currently provide care for the member? And who will perform the care if the home health aide is not available? Outreach to the provider on 12/13 to sign the LOMAN and to request clarification as to whether the request was for skilled nursing or home health aide level of care. Case notes do mention that a peer-to-peer was attempted ×3 with 2 phone calls and 1 fax. However, it does not mention if any messages were left or any outcomes from these attempts. I'd like to point out here that it is important for the detailed case notes to be documented and provided to the DHS clinical review staff. Outreach to the member's grandmother occurred on 12/14 to explain the authorization process, and at that time, the grandmother informed the case manager that all information was provided to the prescribing physicians. The following were addressed during the conversation with the grandmother, including care gaps, durable medical equipment needed, school hours, work schedule for the grandfather, and work schedule for the grandmother. Services were denied on 12/20 because the grandmother was an able and available caregiver. Clinical review staff noted strengths of the number of peer-to-peer attempts to fulfill the Health Choices Agreement requirement, the initial outreach and communication with the grandmother. The MCO had the provider correct the LOMAN to specify the skill level of the request and to sign. Areas for improvement noted were SDOH needs were not addressed. The grandmother was assumed to be willing, able, and available despite having to quit her job to accommodate for members' needs. The denial prior to the 14-day requirement for additional information submission without provider confirming the receipt of all necessary information. The denial was found to be not appropriate by clinical review staff. It does not meet the OPS memo requirement of addressing whether the caregiver is able and available. The grandmother had a job that she had to give up to be available to meet the care needs of the member. There must be sufficient evidence in the case notes or a documented conversation with the grandmother stating she is willing, available, and able to care for the member. This must be addressed in order to determine medical necessity. To reiterate, the denial decision was made after 8 days. This was made prior to the required 14-day allowance for additional information, and there was adequate time to have additional discussions with the caregiver to determine availability. There were no noted additional outreaches to the provider for information. The outreach for the signed LOMAN, the issuance of the N7, and the 3 attempts at peer-to-peer once the decision was made. There is no proof that the MCO confirmed with the prescribing provider that all information was received prior to the denial. And there was no effort to determine if the grandmother would be able to help provide care for her family since taking on the responsibility for the member. Follow-up should have been conducted to determine the impact of job loss on member's caregiver, and if that was her choice. I'd also like to point out that MCO should leverage all sources of information available to make known medical necessity decisions. If the information is found from another MCO source, such as SNU case notes, that source should be cited in the utilization management case management notes. It should not be assumed that the DHS reviewer is aware of the source. This case highlights the need for case management for the special needs member. Whilst new involvement is not a contractually required part of the UM process, information from assessments results should be involved to help coordinate for the case and assist with determining needs. Shift care was denied because the grandmother didn't have a documented schedule. However, her employment schedule was contingent upon being hired. Additionally, just because a family member does not have a current job does not mean they are able, available, and willing to provide care. They may be actively job searching or in the middle of applying for a job. This also means they will need to be trained on that new job, and this training will not necessarily occur when their actual shift will be. This emphasizes the point that the MCOs need to be talking to the member's family, provider, etc., to get a holistic picture of the situation. Sample case 2 involves an 11-year-old child. The date the request received was 12/13 of 2022. History included autism, sleep dysfunction, language and communication disorder. Services needed included monitoring for safety due to impulsivity, poor decision-making, and engaging in dangerous activities to self and others. Complete assistance with ADLs, bathing, dressing, meal prep, toileting, and incontinence care. Hours requested were for 8 hours per day, 5 days a week, home health aid care. On school days, 2 hours prior to and 6 hours after the school day. Case notes include a signed letter of medical necessity was received. It was written on 12/11/2022. Attends school in a special education class, has an IEP or an individualized education plan in place, and receives supportive services from the school. Requires one-on-one supervision due to disruptive behaviors. The mother is the primary and sole caregiver and had to quit her job because she was unable to accommodate caring for the member. She is in the process of becoming a paid caregiver with the home health agency. The child has one sibling, and the mother's significant other who resides in the home will not be involved in the member's care at all. This person works from 5:30 a.m. to 6 p.m. and sometimes longer as needed. An N7 was sent on 12/14 of 2022 requesting the following: to clarify what had changed with the member that he now requires a home health aide, to submit a copy of the IEP or developmental pediatrics note, clarify if the member takes a bus or if the caregiver takes them to school, submit a copy of the member's school schedule, to clarify if there are other children living in the home with special needs, and how the member is currently being cared for and why this arrangement can't continue. Outreach to the mother using a Spanish language interpreter occurred on 12/14 of 2022, where the additional information required was discussed and the mother agreed to send the IEP, school schedule, and the doctor's notes. That additional information was received on 12/19, including the IEP, school schedule, and developmental pediatric visit notes. Outreach to the provider's office also occurred on 12/19 to confirm that all information was provided. Case notes indicate that 2 attempts at peer-to-peer were made, no response to either attempt, and no third attempt was documented. The services were denied on 12/19 because a home health aide is someone who helps with activities of daily living, feeding, bathing, getting dressed. They are not regular child care. Strengths of the case included good outreach to the mother and the provider to get additional information. Areas for improvement were missing third peer-to-peer attempt, that it did not allow the requesting provider the full 14-day window to submit all information, and did not outreach for discussion to obtain any missing information. It was ultimately found that the denial is not appropriate because the medical director did not establish nor explain that the services were not medically necessary. Important points to note in this case is that medical necessity is not affected by the presence of an IEP. While it can show exactly what is being done while in school, it does not preclude the MCO from authorizing medically necessary care. The medical director did not outreach to the provider to discuss whether the requested care is beyond what is customary for the member's peer group. The care needs were not discussed with the parent. An MCO medical director needs to provide specific rationale regarding the member and cite specific details that show the services are not medically necessary. This information must be addressed specific to the member and be present in the denial letter. Also, if the MCO medical director is going to reference regular child care, this should be defined. This case also points out what is the difference between what is expected of a parent versus a home health aide. There is a difference between what a parent customarily does versus when a home health aide may be needed. Decisions must be made based on the child's needs and support for their ADLs. What is the level of engagement needed? For instance, for minimal assistance, it may be appropriate for a parent, but if the member has mobility or intellectual issues, the level of engagement is going to be at a maximum. There may be cases where a parent may be unable, due to cultural or religious beliefs, to bathe a teenage child of the opposite sex. It is also important to consider different factors, including the developmental age of the child related to their abilities or the family members and their needs as well. Sample case 3 is a 16-year-old child. The request was received on 10/4 of 2022. The history includes Bell's palsy, compulsive eating patterns, bilateral congenital cataracts, hyperinsulinemia, blindness, asthma, severe obstructive sleep apnea, patellofemoral arthralgia of both knees. Services include assistance with ADLs, dressing, meal prep, assistance with eating, and safety supervision. The hours requested were for a renewal of 24 hours home health aide per week flex for 3 months or until the waiver services become active. Case notes indicate that the mother is the primary caregiver and that the child also has siblings in the home. There were no other able, available, or willing caregivers. Mom does work as a hairdresser and her hours vary. The letter of medical necessity states that the hours would be 2 hours Monday through Friday prior to school, 2 hours after school, with varying hours occurring on the weekends as needed. The previous authorization ends 10/20 of 22. There were no additional outreach to the provider or mother. The services were denied on 10/4/2022 for not meeting the minimal hours per day requirement per the MCO policy. The current authorization will end as of the date of the denial notice, which was 10/4 of 2022. The strengths were the denial were made within the timeframe requirements. Areas for improvement include the MCO cannot have a minimal number of required hours. The MCO cannot end a prior approved authorization before the end date of the previous authorization, and there was no outreach to the provider or to the mother for additional information. This denial does not meet the Health Choices Agreement standards of medical necessity. A request cannot be denied for lack of medical necessity if the MCO did not perform its due diligence in outreaching for all necessary information. This is why DHS utilizes a 14-day window. The requesting provider should indicate that all available information has been submitted and that there is nothing else available or until every reasonable attempt has been made based on case management standards. The MCO may also not require a minimum number of hours to be requested to be considered as an authorization, and the MCO must allow the original authorization to complete. When there is a request for increased hours, this does not negate the original request. During the prior authorization process, progress must be revisited to ensure that the decision-making process is well informed. Requests cannot be denied for lack of medical necessity unless the MCO outreaches for information and it is not received. The MCO must be certain that there is not a possibility that some additional information could lead to approval. The process is not a task list that can be checked off as you go. This approach is not acceptable. The requirement is to provide all medically necessary services and to meet member need. It's also important to note that healthcare is currently experiencing staffing issues, and it may be more difficult to get into contact making closely spaced outreaches, including calls, unacceptable. It may be necessary to leave a HIPAA-compliant voicemail, fax, or to send an email to a provider or home health agency in order to get additional information. Shift care families also typically have many competing priorities and multiple outreaches may be required. Although this may be more difficult, this does not mean that the expectation is not the same. Sample case 4 is a 16-year-old child. The request received was on 11/11 of 22. The history of the member included gastrostomy, congenital malformation syndrome, dysphagia, autism, deletion syndrome, and fecal and urinary incontinence. The services needed were skilled per the letter of medical necessity for medication administration. Hours requested were for 16 hours per day, 7 days per week. Case notes indicate the mother is a lone caregiver. There was a request for additional information sent on 11/11 that requested provider and caregiver work schedule. Were there any caregiver health concerns? Who was currently meeting the care needs? Who lives with the member? Who is trained? Who provides care when the nurse is not available? And is the care required at school? And if so, why is the school unable to provide the care? Per the case notes, no additional information was received, and the MCO made multiple outreaches to the prescribing provider and to the mother to obtain the necessary information, but received no return callbacks or information. The services were denied on 11/30 of 2022 as the mom is a skilled caregiver and hours can't be approved just to give mom a job. Strengths include outreach to the prescribing provider and the mother to obtain information. All required timeframes were met. The areas for improvement were based on the MCO did not base the denial on medical necessity, just that the mother was an able and available caregiver per the MCO. It's found that this denial was not appropriate by Health Choices Agreement standards. The rationale provided is not based on medical necessity and Exhibit J requirements. Sample case number 5 is for an 8-year-old child. The request was received on 1/23 of 23. It was for a reauthorization with a Loman dated 1/13 of 2023. The history of the member included autism spectrum disorder. Services needed were bathing, dressing, hair, oral and skin care, supervision and hands-on care for bowel and bladder, meal prep, which included finger foods or bite-sized pieces as the child pockets food and forgets to swallow, constant supervision due to lack of safety awareness and risk of elopement. Hours requested were for 8 hours per day, 5 days per week while the mother works. Case notes indicate that there was an N7 sent on 2/10 of 2023 requesting the most recent progress notes from the PCP, whether or not the member had a developmental pediatrician, a current signed plan of care, whether there was shared custody or visitation, and if the member shares time between the member's mother and father's home. They were requesting to send proof of work, including drive time, as well as the father's work schedule with 4 weeks of pay stubs. Services were denied on 2/25/23 because of not having enough information to make a determination. The strengths of this case included the case management notes were detailed and easy to follow. Social information had been assessed and was included in the case. There were also multiple outreaches to multiple sources. The areas for improvement included that if services are medically necessary, they are medically necessary anywhere that the child is, whether at home, school, camp, church, etc. The denial was also not processed following Health Choices Agreement timeframes for decision. If services are not denied in a timely fashion, services should be automatically approved. The denial is inappropriate as written, as it does not follow the Health Choices Agreement guidance related to making determinations based on medical necessity. If determining medical necessity can be made without creating unnecessary hurdles for the provider and the family to overcome, such as the notes for the developmental pediatrician are not necessary to prove medical necessity, this cannot be a reason for denying services. This denial rationale does not list what specific items are missing. The medical necessity is not based on location. If necessary, services can be provided at either one of the parents' locations. If the home health agency is going to staff the member and the home health aide agrees to go to either place, the services should follow the member. Sample case 6 involves a 15-year-old child. Request was received on 11/28 of 22. History of autism spectrum disorder. Services needed were for safety based on elopement. The hours requested were for the member to attend school. Case notes indicate that the father is the primary caregiver and works 40+ hours per week outside of the home. The mother has behavioral health needs and is a questionable caregiver. The child has a supports coordinator through waiver that provided the information regarding the urinary and bowel incontinence. The member was unable to attend school due to not having supports at school to address this incontinence. There was no N7 sent. There was no outreach to family, and there was no outreach to the provider. The services were denied on 11/29 of 22 for only having the behavioral health needs. The strengths include that the denial decision was within the required time frame. Areas for improvement include that there was no use of the N7 and there was no outreach to the provider or family. It was determined that the denial is inappropriate. It does not meet the OPS memo or the Health Choices Agreement standards for outreach related to additional information. No outreach to family and caregivers does not meet the expected level of case management for members with special needs as defined by Exhibit NN, and medical necessity was not addressed. Behavioral health needs can also have physical implications. The MCO did not reach out for any additional information despite having noted physical manifestations of developmental issues, such as the incontinence, that very well may have required shift care. This information was in the internal case file and should have been known to the MCO case manager. MCOs must look at the entire patient, not just the diagnoses. It's also important to point out that there is a difference between behaviors and a behavioral health diagnosis, and certain behaviors should weigh into whether services are necessary. For example, an autistic child, when bathing, can become combative or exhibit unusual behaviors. Some MCOs have stated that they don't think they should be paying. DHS does not concur. Just because it is a behavior or there is a behavioral health diagnosis, that does not exclude the PHMCOs from responsibility. Children on the autism spectrum may have a lot of behaviors that may make care difficult. This is not a reason for not providing a service. Additionally, for elopement, if there is a safety issue, that is probably a reason to allow for services. You can't just deny services because it is elopement and safety and the MCOs are not responsible for that. You have to look at what is happening in the family unit as a whole. While it may be acceptable to deny services for a child that doesn't need hands-on care for daily living, it is not okay to simply deny because they have a behavioral health diagnosis. MCOs are expected to work and to coordinate with TSS or other services that are available based on behavioral health benefits. The intent is not to deny responsibility, but to supplement and to make certain that a child is getting the appropriate and medically necessary services. This should not be used as a reason for denial, but should be encouraged to get the behavioral health services involved. The ultimate goal is to keep families strong and together by meeting member need. It is not a favorable outcome to disrupt the family by sending a child to a residential treatment facility or to a higher level of care. MCOs need to think of the big picture. Why is the request coming in? What are the alternatives to help with this family? What are the real needs? What is medically necessary? And how can we help the child and the family? Sample case 7 involves an 8-month-old child. The request was received on 5/7 of 23. History includes traumatic brain injury, failure to thrive, delayed gastric emptying. The services needed were for skilled nursing for vent maintenance, feeding tube, turning and repositioning, and skincare. Hours needed were 50 hours per week, 8 hours overnight, Monday through Friday, along with 10 hours of flex. The case notes indicated that the child must use a CPAP when asleep. The mother is an RN and states that her schedule is flexible. She is contracted to work 15 hours a month for her job, but often works up to 18 hours per week. This case also involved a third-party payer. There was no N7 sent, and there were no outreaches to the prescribing provider or to the family. There was no sleep schedule requested for the member who must use a CPAP when asleep. Services were denied on 5/8 of 2023 for a lack of information. The member's pediatrician submitted another request for skilled nursing with the mother to provide the daytime hours on or around 5/8 and was reportedly told by an MCO representative that they will not process a new request only for a parent to be paid. There was no denial notice received. There were no strengths noted in this case, and the areas for improvement included that to deny for lack of information, additional information must have been requested. Denying outright because an MCO doesn't have the information is not appropriate. There was no outreach to the family. There was no outreach to the provider for a peer-to-peer or after denial. And the MCO would not even begin to process because of having the mother be the caregiver. It was found that this denial was not based on medical necessity. It also was denied for a lack of information without the use of an N7. It is not within the purview of the MCO to determine who meets the member's needs. That is the responsibility of the home health agency. All requests for prior authorization of healthcare services must be handled per the Health Choices Agreement. Verbally telling someone that a member doesn't qualify for services for whatever reason does not meet DHS's expectations or the Health Choices Agreement requirements.
All questions from the training day and the pre-test questions will be addressed in a question and answer document, which will be provided with the presentation recording. Should you have any follow-up, please reach out to your clinical care representative. This presentation was created using the following resources: the Health Choices Agreement, the OPS Memo, CMSA Standards, the Fee-for-Service Provider Quick Tips, previous denial trainings, and we would like to provide the EVV training materials. This training was done by another department within DHS and is here for your convenience. So moving forward, the MCOs are responsible for ensuring that providers and their partnering home health agencies to be fully aware of the department and the MCO's expectations surrounding shift care requests. Just providing a section in the provider manual and/or their contract is not adequate. The MCOs need to educate the providers and work with the home health agencies to ensure that expectations are clear and are being met. This education cannot happen just once, but must occur often and when needed. Is home health agency education necessary? If a person is qualified to be hired by an agency, the intended recipient of those care services are not typically made known when the person is hired. Whatever agreement exists between the agency and one of their employees, as long as it meets employment regulations and standards, is irrelevant. This process begins with the MCO approving services based on medical necessity. Then it goes to the home health agencies to staff those approved hours by employing appropriate personnel. How often is the member caregiver education provided, and how is that provided? These are things that the MCOs must think about and adjust their internal processes.
Thank you for reviewing the Pediatric Shift Care Training. If you have any questions on an ongoing basis, please feel free to outreach to the clinical team here at BMCO.